So difficult encounters are a problem in medicine. They result in administrative burdens, leading to less time spent with patients. Uh, they lead to complaints that require time to respond to and that could adversely impact revenue, i.e., things like negative reviews, no-shows. They probably result in more litigation claims, and they almost certainly lead to physician burnout. They're also probably associated with more negative outcomes, although there are only a few small studies that have examined this, and those have been done in primary care settings. My name is Stephen Cohen. I'm the Edmund I. Eager Endowed Chair of Anesthesiology at Northwestern University Feinberg School of Medicine and a professor of anesthesiology, neurology, physical medicine and rehabilitation, psychiatry, and neurological surgery, as well as a professor at the Uniformed Services University of the Health Sciences.
I'm Tina Doshi. I am an assistant professor and pain medicine physician in the Department of Anesthesiology, Division of Pain Medicine, and the Department of Neurosurgery at Johns Hopkins University School of Medicine.
And my name is Winnie Liu. I'm a second year medical student at Johns Hopkins School of Medicine. I've been doing a lot of research in the Department of Anesthesiology here at Hopkins.
This video is on the article entitled Difficult Encounters in Chronic Pain Patients, a Cohort Study. It will be published in the January 2025 issue of Mayo Clinic Proceedings. Despite the factors that are typically thought to be associated with difficult encounters, things like psychiatric conditions, unmet expectations, including around prescribing opioids, and the subjective outcomes that often result in these unrealistic and unmet expectations, there are no studies that have been conducted in this arena. So when we were tasked by our interim chair, Adam Saperstein, to conduct a quality improvement project, it's this topic that we decided to tackle.
So in our study, we had 428 patients total, and we had physicians independently rate the difficulty of each encounter on a 1 to 6 scale, and we averaged the two physicians' ratings. So we have 1 being very pleasant and 6 being very difficult. And then a score that was 1 IQR above the median of Likert scores was what we considered as the threshold for defining a difficult visit. So after our definitions, we found that 15% of the visits were considered difficult encounters. And most of the factors we anticipated were found to be linked to a difficult encounter, though there was a lot of strong overlap among all of these factors. These factors included things like unrealistic expectations, requests for opioids, a refusal to try a recommended treatment by the physician, as well as hostile or threatening behavior, which in hindsight, all makes sense because these inherently strain the effective doctor-patient relationship during clinic. The encounters that took longer than expected were also associated with difficulty, and we hypothesized this is possibly due to communication barriers or extra time spent working with the patient, as well as additional challenges that impacted clinic flow. But I did want to emphasize that these communication barriers are not due to English not being a patient's primary language, but rather just the nature and tone, such as like a hostile tone of the communication itself.
So the study identified several factors that are associated with difficult patient encounters. And it's important to recognize that although many of these factors seem to be outside the physician's control, there are ways to mitigate the impact of those factors that we may want to consider. So in the multivariable analysis, the factors that were associated, as Winnie said, were more difficult encounters that were related to patient behavior, and specifically when the patient's behavior did not align with what the physician expected from the patient or from clinic patients in general. As physicians, we all have this idea, or at least a hope, that our patients are not going to request opioids, that they're going to take exactly as long as their appointment is slotted for, that they're going to treat us politely, that they're going to try everything that we recommend, and be completely clear in their communication to us. But the reality is that even though we expect and hope that those things happen, they often don't. And so to make encounters less difficult, we need to understand what it is about these encounters that make them difficult, and then prospectively consider what it is that we can do to lessen their negative impact. For example, if an encounter is difficult because a patient refuses to try recommended treatment, one approach might be to acknowledge the patient's refusal, probe their understanding of the recommendation to ensure that they fully understand the risks and the benefits of what you are recommending to them. And then if you're assured of that, acknowledge that you as the physician are making a treatment recommendation based on your clinical judgment and trying to inform the patient of their options, but that ultimately the patient has a right to decline treatments. Or another example is if the patient is exhibiting hostile or demanding behavior, make sure to educate physicians to stay calm and respectful of the patient in spite of that, to listen beyond a patient's tone to understand and address their concerns, while at the same time creating a work environment where the physician knows that ultimately he or she will still be safe and supported if a patient becomes aggressive. So these sorts of things don't make patient care any less challenging, but they can lessen the downstream consequences of patient dissatisfaction and physician burnout. These ideas are certainly not unique to pain medicine, and I think that they can be generalized to any medical specialty that involves having difficult conversations with patients facing medically complex issues.
This is an interesting study because it's the first to examine factors associated with difficultness in a population known to be difficult because of a high co-prevalence rate of psychopathology, because we use subjective outcome measures, because of issues surrounding opioid use, and requirements for procedural authorization that are beyond the control of physicians. Patients don't always understand that. But our follow-up study, and the one our sample size was powered for, is to see whether difficultness, expressed as both a binary and continuous variable, is associated with treatment outcome, including being lost to follow-up and not showing up for an appointment, which have financial ramifications. And again, I encourage everyone to read this interesting article.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.